from Memorial, not too far away. And we've divided this up to focus on the first line options and then what to think about after patients have progressed, which we don't like to have to think about, but we do need to have an idea of what's available in the future. And so I'm going to start with this concept of how we start with EGFR mutation positive disease, the options we have, and how we might decide. These are some disclosures about some of the companies that make some of the agents that we're talking about. And I just want to take a moment to step back to a time 10 years ago that led to all of this. Because before then, we knew about EGFR inhibitors, and we knew about some patients who responded well. We knew that those were more commonly women, Asians, never smokers, and certainly those with adenocarcinomas. And a lot of the debate was about whether we needed to do testing for mutations at all, or whether never smoking status was good enough. And this trial loomed large at that time. We knew that a subset of patients did well. This was done in Asia, and it directly compared standard chemotherapy to one of the early EGFR inhibitors, Iressa, also known as gefitinib, and I'm going to use the marketed names because they're more accessible to people, but that's gefitinib. And this was done at a time before we were routinely testing for mutations, but meant to capture what we expected would be a huge proportion of people who would benefit from Iressa. And what they found was, as shown in the curves on the bottom left, and I'm not sure how often you have seen these so-called Kaplan-Meier curves, but the idea is that the numbers going down represent things getting worse, in this case, the progression of the disease. And when you see gaps in the curves, it means that one group is doing far better than the other. It's the people who are on the top curve, doing better for longer, with time as moving from left to right in all of these. And so what you'll notice is that there's this hourglass or tipped hourglass shape, the crossover of the two arms. In the beginning, it looks like one group's doing better than in the right-hand side of the curve, a different group is doing better. And that suggests there's actually two groups in there. And so at that time, they did a look at about a third of patients who they had tissue from, and they looked at the actual mutations. And even though this was from Asian never or very light smokers, 6% had a smoking history, Asian never smokers, who at that time was our code for people likely to do well with EGFR inhibitors, they found that the results were totally different depending on whether you had a mutation or not. And 40% of the patients did not. So that in itself is an important factor, that even if you're an Asian never smoking woman with an adenocarcinoma who we thought, well, there's your chip shot, we already know what to do. Well, 40% of the time, they did not have a mutation. And the concerning thing was that if you didn't have a mutation, you did way better with chemotherapy. That's this arm here, EGFR mutation negative, carbo and paclitaxel. Old school chemo was better. On the other hand, gefitinib was way better for the patients who did have a mutation. And that was followed by many years of studies of groups that were now enriched for patients who did have a mutation. So we stopped really at that point. That was a quantum leap, defining that what matters is the genetics, the mutation status, and not clinical definitions. You cannot use shorthand to say, never smokers, that's good enough. No. you had to do the molecular testing. But if you found that patients had a mutation, there were a whole bunch of trials of various EGFR inhibitors. Jeff here is gefitinib or Iressa, Earl is erlotinib or Tarceva, and then afatinib, which is Gilatrif. Various trials of varying sizes, but all EGFR mutation positive patients, and all really showing the same trend. Response rates were far higher, about twice as high if you have an EGFR mutation and got an EGFR inhibitor compared to the chemo. Progression-free survival, the time before the cancer progressed, significantly and often about twice as high in the patients who got EGFR inhibitors compared to standard chemo, but not a big change in overall survival. And the reason that we've really long presumed is that if there's any group where you desperately want to get EGFR inhibitors sometime, even if it's not first, it's patients with an EGFR mutation. And fortunately, most of the patients in most of these trials went on to get an EGFR inhibitor after they progressed on chemo, which is exactly what we'd want. The challenge is that it makes it harder to figure out how much that improves survival, because it's really just, do you do 2 blocks north and then 3 blocks east, or 3 blocks east and then 2 blocks north? Hopefully you're going to get to the same place about the same time. And so, but we also know there is some attrition. That's really part of why we really want to give our best drugs up front, because one way to make sure that everyone gets their chance with the best drug is to give it first, rather than to give something else and then hope and plan that when someone progresses, you'll give it later. Because every once in a while, there's going to be progression that could be really significant, especially if it's in the brain, or what we call leptomeningeal disease. And people can get sick in a hurry, and the last thing we'd ever want is for people to miss that great opportunity to benefit from these drugs. But one other point that you can see is that there wasn't an obvious sense of any one of these agents, whether it was Iressa, Tarceva, or Gilatrif, that was way better than any other. They all showed the same patterns, and we ended up largely choosing based on our comfort level and really the balance of how we perceived how well it worked and the side effect profiles. Because these drugs all have very similar side effects, and I think many people here are very familiar with those, primarily being around rash or other skin or hair toxicities and diarrhea, and a few lab abnormalities, dry mucous membranes, things like that too. But it was really largely just varying degrees. And in the US, Tarceva has been one that was very frequently used because of our long history and comfort with it, and what we really saw as a good balance of how well it worked versus the side effect profile. But it's been hard to show a survival benefit. So those are first and second generation agents. And then there's another agent now that's increasingly used called Tagrisso, or osimertinib. Now, it was approved by the FDA in late 2015, but as a second-line therapy. And Helena is going to talk some about that, but in the context of patients who have already been treated. But it's also a viable and strong option now for patients in the first-line setting. There are other agents that have been in development that are also later generation EGFR inhibitors. What we don't know yet is whether there's a significant incremental benefit of one over another, or whether you can still get utility from one after someone has progressed on an agent like Tagrisso. But one important and helpful factor is that the shape of these drugs is really designed to hit and block T790M, which is the most common resistance mutation, the reason that patients can have progression of their disease after an EGFR inhibitor worked for a long time, the first and second generation agents really don't hit it very well or block it, but the third generation agents like Tagrisso really do, and they also block the common activating mutations. There are two common mutations of EGFR, one called an exon 19 deletion, and the other is an L858R substitution on exon 21. Those are about 88 to 90% of the mutations in EGFR that are out there, at least initially. And so, these agents, the first and second generation agents hit the more common activating ones that you present with initially, but the third generation ones hit the mutations you develop initially and the leading mechanism for resistance. And so the hope is that you can get more prolonged benefit. What's also important about the third generation agents is they hold the promise of not blocking much of the wild type, or so-called the normal EGFR. Well, EGFR stands for epidermal growth factor receptor, and so the kind of off-target effects, the side effects that we see, and as I said, it's largely skin-related, mucous membranes, dry mucous membranes, eye irritation, can see some hair loss or aggressive hair growth, all sorts of anything, eye, hair, skin, etc., can happen. Those are all less likely to occur if you're not blocking the normal EGFR function, which this doesn't do very much, and it also tends to have less effect in terms of diarrhea. Now, what has really changed the field in the last couple of years has been this trial called FLORA, which was giving Tagrisso, osimertinib, versus what was considered standard of care, a first-generation EGFR inhibitor, namely Iressa or Tarceva, as the first-line treatment. And this was done globally, and the main data that we have from this are with progression-free survival. And the main reason we don't have mature overall survival is because the majority of the people on the trial are still alive. That's good. So I'm glad we don't have that information. Far more people on the trial are just still doing well. But you can see a clear pattern of one arm of this trial, the one in orange, in the Kaplan-Meier curve, we call it, on the left side, are doing better for longer, and that's the patients who are getting Tagrisso. And this was published in the New England Journal of Medicine, which often dictates that this is a new standard of care. And what's also important is that we look at, this is called a forest plot, and it's basically just looking at various different subgroups by sex, by age, by race, and smoking history, whether patients had brain metastases or not, all different factors, what particular EGFR mutation they have. In the patients who were on the patients who did better with Tagrisso, these little bars fall on the left side of the vertical bar. The vertical bar is everyone's doing the same regardless of what treatment, but if patients tended to do better with Tagrisso, they line up on the left. If it's better with first-generation agents, they line up on the right. And you can see every group across the spectrum, whether it's women or men or older or younger, Asian or non-Asian, smoker, non-smoker, brain mets or not, regardless of your starting EGFR mutation, all of these patients are doing far better with Tagrisso than with the standard of care up to that time. Now, there's not a lot of difference in the probability of tumor shrinkage, but that's because we're really bumping our heads against the ceiling here, that the agents we've had are really quite good. Tarceva has done a lot of good for a lot of patients with EGFR mutations, so has Iressa before that, so does Gilatrif. These are all agents that are, if that's all we had, we wouldn't be unhappy with that. They can really help, but you do see a higher response rate, a little bit, 80% versus 76%, and a little more of a chance of getting deeper responses, these complete responses where you can't even see any cancer. But the biggest difference is in the duration of response, and that you can see in this curve here, or what we call the median duration of response. Well, the median anything is the point where half the patients have had something happen and half have not. So if you have 100 patients, when the 50th person has crossed over. So this means that you have twice as long, basically on average, before the cancer progresses on Tagrisso than the standard of care. The number here is maybe a little lower than you would hope to see with some of the studies that we've looked at. I think that's a reflection of this trial actually enrolling about 2/3 of the patients in parts of the world where they routinely used Iressa, which, as I said, is a good agent, but I would say is the weakest of the siblings here, that it's marginally less effective. Not a huge difference, but it does, I think, show up that if you were using just Tarceva, it would probably be closer to 10 months, and with Gilitrif might be 11 months. So there's subtle differences, and that's, I think, where we get to the balance of how well it works versus the side effect profile. So you do get a few more responses, and they just tend to last way longer. We don't have, as I said, the mature overall survival. We should be getting more information. This was initially presented in September of 2017, and it's now been enough time that we'll probably see these results later this year. Obviously, there will still be patients alive. That's great, but we'll have enough to get further time information. And I think there's a good chance that it will show that there's more patients who end up living for longer by starting with Tagrisso than with one of these first-generation agents. Here we see what's called a hazard ratio of 0.63. It's a mathematical calculation that basically shows a 37% better survival at any given point on the curve on average. So this is not called statistically significant, even though this, what we call a p-value, is low. P-value is the probability it occurred by chance. But this is still, just because it's an early look, that we need more follow-up. But it certainly looks encouraging that Tagrisso is giving much longer responses, much longer time before patients will have progression, and at least a strong hint that it could well translate to improved survival. But as I've mentioned, it's not just about the efficacy of a drug. If a drug is working longer and you may live longer, but you wish you were dead during that time, that's not good. But that's not the case here. It's even better when drugs are working well and you feel better and really don't have many side effects. We've been pretty happy with how well the EGFR inhibitors, and particularly the first generation ones, are tolerated, but there's some room for improvement, and you tend to have less rash and less elevation in liver function tests, the lab-based tests of how your liver is tolerating a treatment with Tagrisso than with the other standards. Now, I would say it's not necessarily prohibitive with the older drugs. Tarceva tends to be a little harder to tolerate, and there's a lot of patients who do better with a dose reduction on that. And I think because of that, when they pooled these results for the so-called standard of care on the right side, I think they look less concerning than they are in practice, in part because 2/3 of the patients got Iressa, which is easier to tolerate, just somewhat less effective. But in practice, I would say that most patients who I've cared for are very, very, very happy with being on Tagrisso. Many have been previously on another EGFR inhibitor and got it second line. They did fine with that, but they found the change to Tagrisso to be a cakewalk. And I wouldn't say it's always that case. You do need to sometimes watch the heart rhythm, and I've had occasional patients who have trouble with appetite or sometimes rarely lightheadedness, but most people, rash and other common side effects are very uncommon with it and very mild. So you're not having to make some Sophie's choice between doing well with a therapy but struggling to wonder if it's worth it every day when you take the pill. Now, the other area that I wanted to get into, and I'm going to be talking a little more about this in the afternoon session, is the brain as a separate compartment. We didn't used to think that much about the brain because we could never do anything about it. It was kind of like the weather. I mean, there's no point in whining about it if you have no alternatives. And we never had anything that was very good at treating in the brain. That changed. First, the newer ALK inhibitors did a very good job. So our colleagues down the hall were kind of giving us a sense that there might be some real value in some of these newer drugs treating brain metastases with something other than radiation, which was our go-to approach for a very long time. And we'd heard about occasional cases of patients who could have responses of their brain metastases to some of the earlier EGFR inhibitors, and even one of the most feared side effects, or feared complications rather, of what's called leptomeningeal carcinomatosis, where there's cancer deposits in the cerebrospinal fluid that bathes the brain and the spinal cord. That can be a very small amount of cancer causing a lot of problems just by, it's just kind of a rat in the control areas chewing on the wires, doing a lot of damage, even if someone's body scans look fine, but they can be declining right in front of you over a course of weeks or a couple of months. That has been very hard to treat because our drugs didn't get in very well. And one of the ways that we historically tried to do that was using so-called pulsed Tarceva, which is giving a big dose once every week or once every 4 days, so you could kind of hurl some up over the wall and get it behind that and into the brain, and you would see some patients who responded. This was not something we had a lot of good data to support. It was just people had 1 out of the 3 or 4 cases where they tried this in, where people seemed to do better for a few weeks, or if we were lucky, a few months before the cancer eventually found its way around that. Things changed with some of the newer ALK inhibitors, and then also with Tagrisso. And you can see here that this is the same FLORA trial. This is, again, a very active control arm of first-generation inhibitors. This is progression-free survival. So again, being on the top line is better. And then this is showing that within the brain, patients who got Tagrisso tended to go without progression in the brain for a lot longer than patients who are on one of the first-generation inhibitors. And this, and here you can see one of the terms we use a lot is CNS, which is central nervous system, basically brain. So just anytime you see or hear CNS toxicity or CNS metastases, we're talking about in the brain. It's just synonymous with that. And that's how it's going to appear in a lot of the abstracts or whatever you might find online. But this is just looking at the combination of progression in the brain or outside the brain, and showing that in the patients in blue, the numbers, this is kind of the flip side of that. So as the numbers are going up, it's more patients with progression, and that Tagrisso was doing a good job of slowing or keeping patients from developing progression, both within the brain and outside the brain, or dying from some reason. And so this is actually showing that even compared to drugs that can work in the brain, these drugs work a lot better. And that is becoming an important factor as well, because we have known that the brain has been a bit of a sanctuary site or an Achilles heel for us, because as patients are living longer, we love that, but one of the weaknesses has been that too often disease can sneak into the brain and progress in the brain, and that's been one of the frustrating challenges of, we have people doing well on these earlier agents for months or a year or two, and then they develop brain metastases that we just haven't been able to deal with. Well, this not only targets this molecular mechanism of T790M that's been a vulnerability, but also gets into the brain better to treat a whole area that was just not being effectively treated, or nearly as effectively as we'd hoped for. And this study, or this is again a waterfall plot, so downward, each bar represents an individual patient's outcome, and the more downward you are, the more shrinkage there is, just showing that on the Tagrisso arm, there are more patients with their brain metastases shrinking, whether they got those radiated or not. The little R is for, or the capital R here, is for radiated lesions, but whether they were radiated or not, more patients with more of these shrinking, and the kind of brick red color is a complete response. No evidence of that disease was only seen with the Tagrisso arm. And these are not large numbers, but they're all telling the same story here. And that is, it could be because of the added efficacy overall, the tolerability, and the brain metastases are all strongly arguing why we would be inclined to think about using this first. And then this is just one more study. This was second line in patients who had T790M develop, and comparing Tagrisso to chemotherapy, showing that chemo was less effective really than we saw with the other EGFR inhibitors. So it's really the same story, that it was better than the earlier EGFR inhibitors, and it's way better than standard chemotherapy. Now, there are some other agents, and one is called dacomitinib. It's another second-generation ALK inhibitor. Its trade name is Visimpro, and it was FDA approved in the summer of 2018 based on this study directly comparing Visimpro to Iressa in patients with an EGFR mutation, but this excluded patients with brain metastases, and I think that's one of the real issues with this agent. What's impressive is that it did show a significant improvement in progression-free survival. We really, other than the Flora study, haven't seen that one is meaningfully better than another. Here's the curves. Again, the nice separation of the curves is impressive, and there's even an improvement in overall survival here. However, this is in a world where very few of the patients got the opportunity to get Tagrisso. Only about 11% of patients did in this study. So in the US in 2019, if you didn't get it first line, far more than 11% should get it second line. And I think that that would fundamentally change the landscape here and the outcome. But the other big issue is the tolerability. And this is a big issue with this particular agent. And I would say it's really not had much of an impact in our management, nor should it, because it is arguably a little more active than some of the other agents, but the tolerability is a major issue. It has far greater diarrhea, rash, mouth sores, and you might say, well, you can live with that. But the challenge is, these are therapies that are meant to be every day for, we hope, a very long time. And so even nuisance side effects are magnified when you're talking about being on them for a year or 18 months or hopefully longer. So if you don't need to have the side effects, and there's other alternatives that don't incur the diarrhea 4 to 6 times a day, where you live your life trying to think about where a bathroom is, or deal with the rash that's kind of a visible emblem of the treatment you're taking, it's a better choice. So I would say that it's really not the way to go. So another option is combinations, and we have thought about that, and there has been some interest and excitement about the combination with Avastin, bevacizumab, and EGFR inhibitors, particularly Tarceva. In Japan, they've studied this pretty well, and there was a very promising study that was randomizing 154 patients with an EGFR mutation to Tarceva alone or with Avastin IV given every 3 weeks. And you can see this progression-free survival looks far better for the combination. And the early results suggested there may be an improvement in overall survival. And I would say I was impressed by this and did treat some patients with Avastin based on what we knew then. But over time, I would say that it really didn't catch on as a clear standard of care. And the more recent data we have would suggest that we maybe should not be as enthusiastic about this approach. And this is particularly from ASCO last year. ASCO is the biggest cancer meeting of the year. And here again is the progression-free survival curves for the combination looking very good. And just a little more time, no difference there. But overall survival failed to show an improvement. Now, it is encouraging that we have the medians now going to 4 years, which means half the people are doing beyond that. So that's nice to see, but it just didn't appear that Avastin at the end of the day was leading to more people living longer. And although there weren't horrifying side effects from it, it is tethering patients to a year or more often of coming in for IV treatments and higher blood pressure, sometimes headaches, leaking protein in the urine and things like that that were not enhancing your life. And so that's a real limitation, and it really is not justified by any big prize. There's another study that's been done in Japan, very similar, where they basically designed it to repeat the same study, but then have a crossover where if you didn't get Avastin first, you'd get it with the chemotherapy that they intended to follow people with, so you'd cross over to it. And that study has been presented preliminarily. It basically, what they've seen so far is that most of the patients are getting second-line and even third-line therapies. In fact, 2/3 are getting third-line treatments, and progression-free survival looks good, but again, this looks like it may well just go down the same road as what we saw with the other trial. This is a little larger, but there's nothing about this that is making us feel like we should be changing our treatment approach. Again, the leading side effects being high blood pressure and leaking protein in the urine. And if there was a major improvement in survival, that would arguably be worth it. Without it, not so much. And the last combination that I think is actually pretty promising is with chemotherapy. Old chemotherapy, and it's been around for decades, but it's not gone away. And it's always had a place as a second or a third line treatment. But the Japanese are had also looked at this in combination with Iressa, gefitinib, as a first line treatment, and with an intent to have people who started with the Iressa alone cross over to get the same chemotherapy, which was carbo and Alimta, pemetrexed, which is really our favored regimen for patients with an adenocarcinoma. Very good balance of how well it works and the side effect profile. And what they found was that this led to a higher response rate, about 2/3 of the patients with Iressa versus 84% with the chemo and the Iressa. More people going for significantly longer in terms of progression-free survival. And here, this is even better than you saw with Tagrisso on its own. But what I think is most impressive is that it actually led to a better survival. Not a little difference. This is 14 months difference and more than 4 years on average. And this is not with the best EGFR inhibitor. This is with the worst or the least effective of them with Iressa. And it has not taken over the world right now, and I think that is with some good reason. Part of it is this is with a combination that we really don't favor. We don't know for sure that it would be as safe or what the results would look like if we were using Tagrisso. We've been, in general, both oncologists and patients have been inclined to hold the chemotherapy as long as possible. And this doesn't do that. This is, you're not replacing chemo side effects. You're getting that and the side effects of an EGFR inhibitor. But I think this, if it holds up, and particularly it is quite possible that with Tagrisso added to chemo, you could go years beyond this even. And this is the subject of studies being developed and starting to be implemented. I think it's a very exciting thing, and you could ask part of why this might happen, because the Japanese have been very good about crossing over patients when they progress to other treatments. But even though that was built into this trial, a quarter of the patients on the Iressa arm did not get chemotherapy. And that was because they had more extensive progression and the greater chance of a bad, not as favorable performance status. They just were not likely to be doing as well when they progressed. And so there's an attrition rate that I mentioned as a concern. And that chance of not getting your chance to benefit from other treatments that could help was significantly lower if you started with Iressa alone. And another issue that we need to explore is whether hitting the cancer harder up front has some kind of synergistic effect. We're also starting to think about ways to integrate local therapies like radiation to the residual amounts of cancer. That may be part of the story, that if you kick it when it's down, you have even more of a benefit. We don't know that right now. This is, I think some of the next 5 to 10 years kind of questions, but there may be a real value in just doubling down on the cancer when it's at its weakest. And then what about immunotherapy for everyone all the time forever? I mean, shouldn't we be doing that? Isn't it in the drinking water now? And this is a group for whom immunotherapy is not a good choice. This is not a large study, but that's because the trial was closed early. In fact, it was never supposed to be a large study. It was developed and run at UCLA to look at whether patients with an EGFR mutation could do well with Keytruda, as seen on TV. And it was for patients with an EGFR mutation and at least 1% PD-L1 expression, which is about 2/3 of the patients. And the trial closed with 11 patients enrolled because it was alarming how badly the patients were doing. Here's a waterfall plot. You've seen several. You can see there is one patient with a good response. Unfortunately, that's the exception that proves the rule, because that person actually didn't have an EGFR mutation, an activating EGFR mutation. Oops, you throw that patient out, you're 0 for 10. Not one of the patients was responding. And the other concern was that 2 out of the 10 patients with an EGFR mutation died in the first 6 months. That is really unusual, fortunately, with patients with an EGFR mutation. One of them died very quickly after starting Tarceva as a second-line option, and they developed pneumonitis, inflammation in the lungs, which appears to be a more common issue with this sequence of immune therapies followed by Tagrisso. And in fact, Helena's institution just published something in Journal of Clinical Oncology about this being a real concern as we look deeper at the experience. This is not as isolated as we hope it would be, that it's a real concern that you could really harm patients by giving EGFR inhibitors after immunotherapy. So you don't want to jump the gun with it. We need to learn more about it, but the early signals are don't take the bait. These are patients with EGFR mutations, less likely to benefit from the single agents, may be better with combinations, but that is not to be given as the first-line treatment. The best treatment is EGFR inhibitor based, and the question is just which one, and maybe with something else or not. So where does that leave us? Well, many EGFR inhibitors are still fine options. There may be circumstances where somebody can't get Tagrisso first line. I would say that Tagrisso is now generally favored first line in the US or other places where you can get it for several reasons. It has a clearly very superior progression-free survival compared to chemo and compared to first-generation EGFR inhibitors, and a trend toward improved overall survival. We may see more than that with subsequent follow-up. Tolerability is very good, and we increasingly now care about how well it can control disease in the brain, not just disease a patient may have, but prevent disease that can occur later on down the line that we would like to avoid. So if we have that as one more parameter to vote in favor of, that's great. In patients who can't get it because it is not available in their part of the world or they have some side effect issues, other EGFR inhibitors are very reasonable, but we just need to pick one, and it's a question of which one you think is the best. A sequential approach is still advocated by some people, starting with a drug like Tarceva, then waiting until progression occurs, and then you can get your Tagrisso later. The big hesitation I see about that is that you only have about a 50 or 60% chance at most of developing a T790M mutation and qualifying for Tagrisso, and you really don't qualify for Tagrisso if you progress without T790M. A lot of patients in the real world don't get that testing done properly or ever, and so in reality, it would be more like a third of patients ever getting Tagrisso if you don't start with it. And so I think that's a real issue. We do need to explore combinations better. The drugs like Avastin, which is called an angiogenesis inhibitor, blocking the tumor blood supply, is one drug that is still being looked at with other EGFR inhibitors or various ways to study it. And there's other drugs in that class that are being looked at that are quite interesting. And also, I do think that the EGFR inhibitor plus chemo concept is very provocative. The fact that it showed a 1 year plus survival benefit in a well-done trial in Japan needs to be done outside of Japan because we don't always see the same results everywhere in the world. We would like to see it with a EGFR inhibitor that we actually tend to favor, but I think it's a very promising concept that we will be exploring more in trials that are being activated now in various settings. And immunotherapy is worth noting, just to say we haven't forgotten about it, but we don't want to use it. Not to say never, but it is not, outside of a trial setting, an agent that we would favor using in the first line. And the very limited experience we have combining it with some EGFR inhibitors, particularly Tagrisso, has seen issues of pulmonary complications, pneumonitis, that is a danger zone. So this is not something that we would want a patient their doctor finds out that they're PD-L1 high and EGFR mutation positive. You don't combine Tagrisso with Keytruda and see what happens, because you probably won't like it. Anyway, so thank you very much. I'm going to turn it over to Helena to talk about the story in the second line setting, and then we'll have a broad time for questions. Thank you.
thank you, everyone, for inviting me. Yeah, and I think feel free to ask questions as we go along, or I'm happy to answer them at the end, too. And I think some of my slides overlap with Jack's, too, so I will quickly go over those. But what I wanted to talk about was treatment options for EGFR mutant lung cancer, talk about acquired resistance, which is what we, can you not hear me well? Okay, sure. Good? Okay. Acquired resistance, which is the way that we describe when people have growth on treatment, treatment options after EGFR inhibitors, and then some of the new strategies that we're working on. So this all was gone over by Jack. I think one of the things to note, and he mentioned this too, is that initially all the studies of the different EGFR inhibitors were compared to chemotherapy, and then the more recent studies, the FLORA study, that Archer 1050 study with dacomitinib, were utilized the comparison of one EGFR inhibitor to another. But this just clearly shows that using EGFR TKIs are better than chemo. He showed this with dacomitinib as well. So we know that for people that have growth on one of the earlier generation EGFR inhibitors, the predominant way that the cancer gets around is that T790M. And basically having that new mutation prevents the earlier generation TKIs from binding. And that's where, as he mentioned, Tagrisso fits in as a really good inhibitor of that EGFR T790M. And then because oftentimes, as it is in cancer development or cancer treatment development, when something's good in the later line testing, where we often test it first, we bring it up to the first line setting as first treatment. And he showed you all of this data about the FLORA study. Okay, so I'll spend a moment, which I think is what Dr. West was talking about a lot, but I think this is sort of a picture I made to show that. I think one of the things to think about, or what patients bring up to me, is, which EGF, now that we have now 5 choices for EGFR inhibitors, which one should I use first? And as he mentioned, some people bring up, why not start with one of the earlier generation inhibitors, and that would give us Tagrisso to use in the second line setting. And then I think he really nicely went over the fact that many patients don't end up getting T790M, and they've looked at Tagrisso in the setting of not having T790M, and it doesn't work at all. So it really only works in the second line setting if you have T790M. And then I think what's really important to note, which I don't think we think about, is the fact that, as he mentioned, many patients don't actually get to second line treatment. Even in these clinical trials, which means these are really healthy patients that are fit enough to kind of run through and jump over hurdles for clinical trials, 25 to 30 to 35% of people in these studies actually don't get to second line treatment. So that is a huge drop off there. He did also mention the progression in the brain, which I think is really relevant and important, because when patients have progression in the brain, that really is something that obviously brings out symptoms, helps people feel less functional, so really important to try to avoid or put off for as long as possible. So I think, just in summary, I think it's always important when you have different options to use your very best treatment first. I think partly because not everyone gets the second line treatment, and then I think people fixate on, but after Tagrisso there's nothing left in terms of approved targeted treatments. But I think that we are actively looking at sort of new drugs in that space, and either way, whether you get Tagrisso second or first for a longer time, that's the case either way. Okay, so talking about acquired resistance. So, as researchers, we try to study this a lot, where we want to know, for individual people and as patients as a whole, what makes cancer start to grow on treatment that was once really effective and shrunk the tumor. And so a lot of our data as to why tumors become resistant to Tagrisso is looking at it in that later line setting, so people that were on, say, Tarceva, then sequenced to Tagrisso, and what do we know about their cancers and sort of why they become resistant. So this is a busy slide, but this is kind of summarizing four different papers, really looking at, after Tagrisso, what kind of resistance mechanisms do we see. And I think one that's really interesting is sometimes we see histologic transformation. That's actually when the tumor is a non-small cell lung cancer and adenocarcinoma, but after being on treatment, something about being on that treatment makes the tumor change in a way where it looks totally different. And the most dramatic kind of version of that is when tumors are adenocarcinomas and then they can switch or behave and look more like a small cell lung cancer. And I think that's something that's really important to recognize, because those tumors and cancers are, number one, more aggressive, but they're also treated totally differently. So it's really important to identify that, because if you miss that, you're missing an opportunity to treat that cancer appropriately. And so some of these other things, so we can see that transformation. Sometimes, as you guys know, we see second mutations in EGFR, so that's that second from the bottom row. So even on Tagrisso, we don't see T790M because Tagrisso is such a good T790M inhibitor, but we have been seeing other mutations. You might have heard of something called C797S or G724. There are new mutations that, if they are present on that EGFR gene, make Tagrisso not effective. And so those are important things to identify, because I think we're trying to find new treatments for those mutations as well. So I think finding them is the first step to figuring out how to treat them. And then some of the other things here are you can get other other mutations. So there are breakout sessions for ALK and RET fusions. So we've actually seen sort of patients that have EGFR mutant lung cancer, and then upon sort of progression or growth on Tagrisso, we've biopsied them and they actually have an ALK fusion or they have a RET fusion. And so those would be important to know too, because we actually have pretty effective drugs, really effective drugs to treat those things as well. And then some of the other things, this MET-AMP and HER2-AMP, that's when certain proteins become increased, and there are certain drugs that we can use to target that. So I think it's really important to, in some way, whether it's, I know you guys talked about plasma or blood testing or mutation testing or tumor mutation testing, because I think for my patients, if they have growth on Tagrisso, we biopsy them or we send off these blood tests, and sometimes I can offer them a really individualized treatment based on their mutation test results. So I think it really has relevance, number one, for the patient sitting in front of me, and then number two, to help us understand about these cancers as a whole. And I think one thing to remember is I think blood test has an important role, because I think it's easier, it's quicker. All patients really can get that blood sample. But I think there are certain things, in particular, that histologic transformation, when cancers change from adenocarcinoma to small cell lung cancer, you can't find that on a blood test, and that's something that you really only can see on tissue. So I think especially for patients where their cancer was kind of slowly growing and then all of a sudden they get all these new tumors, or the cancer has grown significantly, those are patients where I say, oh, I better biopsy them because maybe there's something there, or I'm worried about that small cell transformation. And then some of these other mutations, like these fusions like ALK and RET, or sometimes increases in certain proteins like MET and HER2, the sensitivity of the plasma or the blood test is a little bit less. So I think, I think there's a role for both blood and tissue testing. So this is some of the data that we are getting together from Sloan Kettering, the hospital that I work at. So we've looked at both. So, we're focusing on tissue because I think that that's the gold standard. So we're looking at tumor samples that we've gotten from our patients before Tagrisso. And then when they have growth on Tagrisso, we biopsy them again. So it's really like we have a good idea of what their cancer was like before, and we're looking afterwards. And these are some of the different things that we found. And so this is osimertinib or Tagrisso in the later line setting. And the slides on the right is a picture of one of my patients who had that adenocarcinoma, which is kind of the slide picture on the left. And then if you go kind of directly down, that's what the cancer looks like when it transforms to that small cell lung cancer. So that's something that we see. And this is a similar pie, but this pie is from the first line setting. So this is a really new evolving area where, Tagrisso as a first line treatment was only approved a year ago. So we're still trying to figure out, as people have tumor growth on Tagrisso, what are we going to see? And is that going to be different than Tagrisso in the later line setting? And something really interesting that we've seen is something, we did see the small cell transformation, but we're actually seeing something called squamous cell transformation. So if you guys remember, there's two different types of non-small cell lung cancer. There's adenocarcinoma and there's squamous cell lung cancer. And squamous cell is one that we typically actually see especially in people who have a smoking history. But we've seen now several cases, more than 5, of people that have had adenocarcinoma, and when we biopsy them, it looks like pure squamous cell lung cancer. And I think there are certain chemotherapies that are better for one type of lung cancer compared to the other. So another thing where it might actually directly change how I treat patients. And then we've seen some other different things. And I think what's important to note here is these are all cases that have progressed on Tagrisso. The average was within a year, so shorter than the average. So we're seeing kind of more aggressive mechanisms of resistance come out first, and then presumably we'll see sort of different things for our patients that had been on Tagrisso for longer. So more to come, but I think we're finding new things, which is, telling us it's important to, again, biopsy people on first-line Tagrisso because what we find is going to be different than what we found with Tarceva. Okay, and so thinking about treatment options. So this is the NCCN guidelines. I'm sure you guys have heard of this, but this is sort of all the big cancer centers come together and help decide sort of how to provide guidelines for people to treat different types of cancer. And so I put this up here primarily because it's thinking about I think the first question, when I have a patient who has evidence on the CAT scan of growth on Tagrisso, the first question I say is, how's the patient feeling and how much growth? Because if we see, 1 or 2 millimeters, tiny amounts of changes on that CAT scan, and my patient feels great, I oftentimes say, I think there's still more mileage that we're going to get out of this Tagrisso. If you're feeling great and I feel like there's been very minimal changes, I think one reasonable option is to say, let's continue for a little bit longer and see if we can stretch that mileage. And then one of the things that Jack mentioned is thinking about local therapies. So there is a not uncommon situation where I have a patient that has multiple kind of tumor sites, and maybe on a CAT scan after a year and a half on Tagrisso, I see one lung lesion growing. So in that setting where all of the other disease is stable on Tagrisso, but there's one lesion that's growing, it makes sense to think about treating that a little differently. So maybe we should think about radiation or surgery or some kind of local treatment to that one spot that's growing, and then be able to continue the Tagrisso for longer. Because I always tell my patients this is a journey or a marathon, so I think the longer we can stretch each of our options, the better. And especially as we've been kind of stressing, an option that's a pill that you take once a day that has certainly less side effects than a lot of our other treatments, I'd like to keep them on that for as long as possible. And then this is just different clinical trial data of that continuing the EGFR inhibitors after we've seen growth. Because I think the key is looking at the patient in front of us and saying, if they look good, I'm not going to treat the CAT scan, I'm treating them, and I oftentimes sort of push on. And then I'm actually going to talk about immunotherapy and targeted therapy subsets later after lunch, so I'm not going to spend too much time on here, but just to say that immunotherapy doesn't look to be a sort of a great option for for patients with EGFR mutant lung cancer, so it's something that I reserve for much later after they've had other treatments. And so I think what might be interesting to you guys is to talk about sort of what are we working on, what's on the horizon in terms of new treatments. So this is another kind of graph to talk about, how we treat patients and how we can sequence the different treatments that we have. And one of the interesting things is now that most of us use Tagrisso as the first treatment if I meet someone today in the clinic, and so say they're on Tagrisso for a year and a half or 2 years or longer, and then they develop, say, like a second mutation like that C797S. There is good data from the lab or from sort of preclinical data that some of the earlier generation EGFR inhibitors might work against C797S. So one interesting question is, can we start with Tagrisso, and then in a subset of patients, can we go back to Tarceva? And I think that's something that we're kind of fleshing out and looking at. So we have a study at Memorial where we're looking at people that have had Tagrisso, they have one of these kind of newer EGFR second mutations, and then we're treating them with dacomitinib, which is one of the EGFR inhibitors that looks kind of to be one of the best of the rest. And then as Jack mentioned, I think something that's really key is, we've mentioned using your best treatments first and really trying to focus on giving the most effective as possible treatments up front. And I think there really is promise in looking at these different combinations, especially because I think it's not as simple as, I wish it was, but it's not as simple as people on Tagrisso, they're all going to, 2/3 of them have this one, way that the cancer goes around the Tagrisso. We're seeing a lot of piecemeal where, 10% might have this, 5% might have this. So I think thinking about a way to improve first-line treatments for everyone becomes really important, because I think the longer we can sort of use that first-line treatment, everyone gets that first-line treatment, the better off that we are. And so this kind of gets to that as well, in terms of, if it was so simple as, say, everyone developing MET protein increases on Tagrisso, then it would make sense, why don't we combine Tagrisso with a MET inhibitor up front? But when we don't have such straightforward, dominant kind of ways that the cancer gets around the Tagrisso, we might have to do things on the back end where, just as I mentioned, if I find a patient that has an ALK fusion, I'll treat them with Tagrisso and an ALK inhibitor. And this is off-label, but thinking about different combinations once I actually have somebody's mutation tests in front of me. Oh, and so there's recent data, actually updated data that was presented at AACR, which is one of the big cancer meetings that we have every year, and that's looking at, in the setting of patients that have had growth on Tagrisso and then have evidence of MET protein increase, or if they have evidence of MET protein increase after Tarceva or one of the earlier generation inhibitors, can we combine an EGFR inhibitor with a MET inhibitor, and what does that look like? It seems to work, and it actually seems to work really well. So people that have had Tagrisso and then have evidence of that MET protein increase, if we add in savolitinib, which is one of the MET inhibitors, 30% of people had shrinkage of their cancer just by adding in that MET inhibitor to something that their cancer was already growing on. And this is one of my patients in that situation, where this is a cross-sectional picture of her liver, and you can see the liver on the left of each picture, and you can see there was a big tumor there, and it did get smaller on the combination. And it's something that I think we've been able to combine safely and really does work really well in a subset of patients. So this is an example of biopsying someone and then individualizing their treatment based on those biopsy results. And then this is something that we published with our patients, but there have been other case reports and case series as well. And these are CAT scans or pictures of patients. So there was a patient that had, as I mentioned, an acquired ALK fusion. And in that setting, I've treated a patient with crizotinib plus osimertinib or alectinib and osimertinib, and we have seen disease shrinkage. And so that's kind of using available targeted treatments, but again, tailored to somebody's specific mutation results. And we've seen that with also RET fusions, as well as another type of mutation is a MET exon 14. And so if we've seen these new mutations, we've been able to combine treatment. So I think this is really promising, and I think exciting to think about really directing, individualizing treatment. And so these are exact slides that Jack went over, so I won't belabor them. But I think, as he mentioned, we know that erlotinib and Avastin, which is that antibody that blocks tumor blood vessel growth, looked promising, at least in delaying cancer growth or progression. As he mentioned, what about combining it with the newer generation inhibitor? So back in 2016, I wrote and opened this study, which is one of Tagrisso plus bevacizumab, so kind of trying to use best-in-class, the most effective EGFR inhibitor, and combining it with Avastin. And so we'll present updated results on this at ASCO this year, but I think it does look to be promising. This was a single-arm study, so the challenge with that is we treated 50 patients, but all of them got the combination. And the way to really understand whether one treatment's better than the other is, of course, to do a randomized study where half the people get the Tagrisso, half the people get Tagrisso plus Avastin. And so one of the studies I'm posing for one of our cooperative groups, which will hopefully get off the ground, is exactly that, giving half the people Tagrisso and half the people Tagrisso plus Avastin, and seeing if we can, number one, replicate that progression-free survival benefit of more time on treatment. But I think, as Jack mentioned, the key is survival. We want people living longer, really making an impact in their disease course, so we have to see that. And then this is the same study that he showed. I'm also very intrigued and interested by this, and this is that study that showed that gefitinib versus gefitinib plus chemotherapy, there was improved survival as well as delayed progression with the combination. So I think one thing to think about, there are studies that are going to be opening using Tagrisso plus chemo, so Tagrisso versus Tagrisso plus chemo. And then I think another sort of way that we need to think about things is, as he mentioned, there are people that we start on Tagrisso that 3 or 4 years later are doing fine. So, I don't want to, and I think the key is trying to figure out ways for us to individualize treatment. So if there is a way up front to kind of take 100 people with EGFR mutant lung cancer, we know some of them will do really well, and we know that some of them have more aggressive disease. So is there a way for us to find and select out those patients that have more aggressive disease that are going to progress earlier, and maybe those are exactly the people that we would want to escalate treatment. For those people, the potential increased toxicities of chemotherapy plus the EGFR inhibitor would be worth it, because I could say something about you and your cancer is high risk, so let's find a way to escalate treatment for you, but for someone that's going to be on Tagrisso for 4 years and be fine, leave them be on the Tagrisso. So I think that's the next kind of, in my eyes, the next sort of area of looking at figuring out high-risk patients within kind of a subset of people. And okay, so what's next? So one of the things that we're also looking at is, can you combine, so if one EGFR inhibitor is good, is there a reason or value in combining two? And as I mentioned, we know that Tagrisso blocks that T790M mutation, but we know that at least in the lab, or the Tarceva or dacomitinib, one of those can be effective against C797S. So if we give the two together, is there a way to kind of delay resistance by preventing all sorts of kind of second EGFR mutations? And so we have a study at Memorial looking at Tagrisso plus dacomitinib. We actually had a mathematician help us model different dosing schedules to figure out, because as Jack mentioned, there's going to be more toxicity with giving two together. But is there a way to figure out an optimized dosing so that we can give the two together? One of the things, a goal of ours is, kind of preventing certain resistance mechanisms from emerging, particularly ones that are really aggressive, like small cell transformation. So we're taking people with specific mutations, this RB and TP53, which are two mutations we see with EGFR about 10% of the time, and we're giving them treatment that sort of addresses the potential small cell transformation. So I think we'll see more of this too, what we call adaptive study design, where we're taking patients and then somewhere in the middle of treatment, changing their treatment based on risk factors. So taking high-risk patients and escalating their treatment. So this is something that we have ongoing as well. So I think in conclusion, I think of that motto of trying to use our best treatments first, I use Tagrisso as my first-line treatment. I think that we're seeing very diverse resistance mechanisms to Tagrisso, and I would put them in 3 categories of on-target resistance, which means acquired EGFR mutations, off-target resistance, which means different mutations like those ALK fusions or RET fusions we're seeing, and then that histologic transformation where we're seeing both small cell and squamous cell transformation. And I think it's a little more tricky because everyone's going to have different things, so we can't treat everyone the same. I think it's going to be really important to figure out how to combine treatments with EGFR inhibitors, and I'm particularly interested in thinking about Avastin or chemotherapy. And something I'll talk about later this afternoon is what's the role of immunotherapy in this population. And then I think looking at and kind of tailoring treatment to different people will be really important based on their mechanisms of resistance. So that's all I had, and I'm happy to answer any questions you guys have.
So Helena and I spoke forever, which is good because we covered, I'm sure we answered every question, but we have a good amount of time for the lunch break, and we'll take at least 10 minutes or so to cover questions. I saw there were a few hands that came up, so go ahead, please.
Yeah, I have a hard time understanding one thing, and it could be because my original diagnosis was 18 years ago when they only had chemotherapy.
Yeah.
And I just don't know if there's a place for chemotherapy first, assuming there's no brain mets, because it is effective at times, just like targeted therapy. Some people respond, some people don't.
Yeah.
I was just wondering if there's a place, if you've ever thought about chemo alone, a combination, I don't mean one chemo,
Yeah.
but without any targeted therapies first, because there might be a chance of a response, being that the fact if you go straight to the targeted therapies, you have more of a chance of all the mutations that you don't have with the chemotherapy?
Yeah, I think it's a good question, and I think that, congratulations on 18 years, first of all. But I think, we're learning as we go along too, so I'm sure that your doctors kind of at each step along the way. 18 years ago, we didn't have targeted therapy. We did not use that. So I think, our goal is to give kind of the best treatments available at a certain time to our patients. But some of the studies that Jack showed were patients that got patients with EGFR mutant lung cancer that either got chemotherapy or targeted therapy. And we did see that sort of the time on treatment and survival were better with getting them up front.
I did see that. I was just wondering,
Yeah.
Trying it up front, and
I think,
there are some response. I don't know how to explain it.
yeah, I think for individual patients, these are just general concepts, and certainly it's an easy choice if they don't exist at the time, the alternatives. But I think what does come up, and I'll be interested in Helena's perspective, there are some people who have very, very indolent small volume disease. And you might biopsy a lung lesion because someone has 2 or 3 that have barely changed over a couple of years. And this also comes up in patients who have had a resection of some lung, and you find an EGFR mutation. But there's little or nothing that's growing at any particular rate. Do you start the clock right then, or do you wait? I personally am not in any rush to have somebody start a treatment that costs $15,000 a month, has side effects, and may just give a big head start to the cancer to develop acquired resistance long before. We don't know that. The other side of the coin is the kick it when it's down. Maybe the same treatment lasts exponentially longer when you're treating small volumes. But no, my general approach has been, if a cancer is growing at a rate that you have to squint to see, don't worry about it particularly. And so that's a concern. Now, I definitely have had patients in whom we just know we have a great treatment in our back pocket, but if you're going 3 years and barely seeing anything grow, I'm not that inclined to start treatment then.
I think, were you talking about, though, Lisa, because we, our groups always talk about this, your thought process being chemo kills cells, but targeted therapy only suppresses them? Is that what you're thinking?
In a way, but I know chemo doesn't always.
Yeah, I would not treat it like chemo is killing cells in a way that the targeted therapies are not. It's just.
It's my mindset, I guess.
Yeah, I mean, I think the only setting where that might be relevant is the early stage setting, where we have proven evidence in lots of clinical trials that have shown that chemotherapy after a resection for an early stage cancer does help people live longer. It cures some people of their cancer, and we're still figuring out whether EGFR inhibitors work in that space. So.
Firstly, I wasn't early stage.
Yeah.
Right, but so I think there's a lot of it that's individualized, so I think we can't.
Right, thank you.
No problem.
Yeah, Ivy.
I have a question about the C797S.
Yeah.
So you were talking about possibly in patients who have C797S going back to a first or second generation EGFR TKI. But how does that interplay with the C797S if it's in cis versus in trans?
So the
Can you
question.
talk about that a little?
So the question was about, and this is for the online audience and posterity, about C797S cis versus trans.
Yeah, I mean, I think that the role where I think that the earlier generation inhibitors will work after Tagrisso would be when it's first line. Because I think one of the questions about in-cis or trans is if somebody has T790M after Tarceva, then they get Tagrisso, then they develop C797S, then that question of in-cis or trans makes a difference, because if the T790M and the C797S are on the same allele, then we wouldn't expect that going back to Tarceva would work. But I think in the setting of using Tagrisso first and you don't have T790M and you just have C797S, that's where I think that there would be activity in going back. So it's only if you start with Tagrisso can we go back to one of the earlier
Okay, so in the
TKIs.
later line, it's only if you lose the T790M, it becomes an option.
Yeah, and I don't even, I think that we're trying to figure that out, because I don't know of any good kind of evidence that if you've been on Tagrisso and you go back, that even if you've lost T790M, that it works. So I think we're still trying to learn and figure that out. But I do think figuring out a way to, if we can incorporate different EGFR inhibitors and sequence them is, something that's really valuable.
Okay.
So a last question, and then we'll break up, we'll have lunch, and we'll be here, so there will be other opportunities. But the question comes online, and it's about what do you biopsy when there is progression? Do you go after lung? Do you go after a bone lesion? And particularly if you're worried about transformation to small cell or squamous. And so I'll ask you to comment, but what I would say is one important thing is obviously you're not going to pick that up from a blood-based test. So even though we're really interested in using plasma to look at how cancer changes over time, it's not the way we detect transformation to small cell or squamous is by looking at it under a microscope. Bone tends to be a challenge when you have to decalcify it. You have to do chemical treatments on it, so that makes it harder to do the detailed molecular testing, but you can still look for this transformation. But the key issue is you go where the money is. So you can have a bunch of lesions that have shrunk, and then they're stable for a year, and then a new bone lesion grows. You don't biopsy what's been stable for a year. You have to biopsy, get the lead runner. You have to go after what's changing, whether that's in the liver, the lung, the bone, or whatever, because that is the area in question. And that is probably has different characteristics than what is still responding in the lung.
Yeah, I totally agree. I think that what we're learning is that resistance is heterogeneous, where, within a person's individual cancer, sometimes we can see different mechanisms of resistance. So I think, number one, we go wherever is safe and accessible, but I think number two, if we pick sort of what looks to be more aggressive or growing, we have a better chance of figuring out or sort of identifying the relevant mechanism of resistance that's driving actual growth and progression.
Yeah. The problem would be if we do want to be safe and go after what's easiest to get, but we don't want it to be an example of the street lamp effect where, well, what's growing is in the adrenal gland, but it's so much easier to biopsy this lung lesion, so I'm just going to biopsy that instead. That's like the drunk who lost his keys in the dark alley but decides to look for it in the well-lit street because the light's better there. So we have to go to the area in question. So thank you for your participation and interest. Thank you very much for doing this. And we're going to break for lunch. We'll reconvene in this room after lunch to have some more general session time. Good.